We're going.
Hi, I'm Dr. Alan Brown, and welcome to this session of Lipid Insights. We have an exciting discussion today. I'm actually very intrigued by it. We're going to discuss the National Lipid Association joint statement with the American Geriatric Society on an expert clinical consensus about something that everyone asks about at virtually every lipid meeting: managing hypercholesterolemia in adults aged 75 or older without a history of atherosclerotic cardiovascular disease. So I think all of us have been at meetings where someone raises their hand and said, should we be treating patients older than 75? With me today is Dr. Joseph Saseen, who is a professor and Associate Dean for Clinical Affairs at University of Colorado. Joe, great to see you, and I'm really looking forward to discussing this document.
Thanks. I'm glad to be here, and it's, I think, an important document that will help our patients and our clinicians to treat them better.
I also have Dr. Vera Bittner, past president of the National Lipid Association and co-author of the document, on the call. So Vera, thank you very much for joining us.
Yeah, thanks for having me.
I should say that Joe's a past president of the Lipid Association also, and so am I. So,
and Vera too.
I said that.
Oh, you did? Okay.
So anyway, let me ask each of you, I guess I'll go to Vera first because I'm in a gentlemanly mood. Vera, what was the background for even considering this type of a document? Was it driven by people asking about older patients over the decades, or what prompted you to pursue this?
Well, I mean, it's basically a document that starts where the guidelines stop. Because if you look at the guidelines, all of the recommendations of, ESC and, the US guidelines basically stop at age 75. And beyond that, there's just a lot of uncertainty what to do. And so the NLA and AGS thought it would be a good idea to kind of collate the data that we do have and come up with some guidance for practicing clinicians.
So Joe, what kind of data do you have, and where did that come from?
That's a great question. We decided this was one of those things that we planned a while back, and it takes a while to get two organizations together with their experts to get things rolling. But the AGS crowd, one of them is a colleague of mine named Sunny Linneber, she always referred to this area as a data desert. But it's not really a data desert. There are data available. It just is not as perfect as far as robustness as what we're used to in treating hypercholesterolemia. So we do have data evaluating statin therapy in older patients. It's not perfect data looking at purely primary prevention. There's some ongoing big trials that will give us very clear answers, but that really was the reason we needed information is in a consensus statement is to know what the expert direction is on how to evaluate patients and interpret the data that we do have available. Some of our data sources are observational in nature or subgroup analyses or parts of bigger studies. When we're looking at the statin world, that's very relevant in our primary prevention population. And we do have some pockets of data with drugs such as ezetimibe and even bempedoic acid. And we do need guidance and reminders that we should start with statins first, but that we do have some options thereafter for patients that doesn't do the job at getting sufficient LDL lowering or when that treatment is not possible for one reason or another.
I think we've all observed that patients seem healthier at older ages, certainly than when we were kids. So people are living longer. And you see many patients come into the clinic who look quite healthy at 75 or even 80 years old. Vera, I'm curious, I'm sure you've heard all the arguments about whether or not primary preventative statins actually reduce mortality. Well, that's not going to be an issue in this age group. But patients in that age group do have a very high prevalence of ASCVD as their major morbidity. And I wonder whether you could speak to the issue of why it's just as important to reduce morbidity as mortality.
Well, it basically comes down to a quality of life, issue. Obviously, under absolutely ideal circumstances, you would want to be disease-free all the way until the end of your lifespan, and then kind of basically, quote, meet your maker after that, but have good quality of life before that. And if you have events in that, the last 10 to 20 years of your life, myocardial infarctions, strokes, things like that, your lifespan may not be affected that much, but certainly your quality of life is going down. And so when I think, thinking of it as, preserving functional life, is a good way of thinking about it in this age group.
So I'm going to ask both of you a little more about what exactly is in the document, but the issue of the fact that we have more and more folks reaching an elderly age and that they make up a large portion of the economics of healthcare, and at least in the United States. Did you think about what the cost benefit would be of treating patients in this age group?
I think that's always in the back of our minds as far as being good stewards of healthcare. I think it also is somewhat of an easy sell when we think about the treatments that we have at hand that are more first line, because they're very affordable. Statin therapy and ezetimibe are not treatments that are overly burdensome from a cost standpoint. I wish we had evidence or data that related to cost effectiveness in this group, and we just simply don't have that, which is the reason we sort of need an expert consensus. I think the overall glean, though, was to be sensitive to those issues, despite not having specific recommendations that address cost effectiveness in this population. It's something you can't get away from. But I think one thing that comes up that's sort of in line with that is we see habits and patterns of what people are doing in practice. So completely ignoring lipids in elderly patients who are primary prevention is incomplete and not what we want to promote, because as you mentioned, the average, let's just say 80-year-old now is very different than the average 80-year-old 30 years ago, because of advances in care that keep people alive longer with fewer cardiovascular events. So we see habits of sometimes people not treating just based on age. So discrimination based on age, numeric age versus physiologic age, trying to debunk that. And some of our recommendations do address evaluating patients more holistically. But also there's this habit of deprescribing that also can be problematic if it's not thoughtful and purposeful. And we sought to address that also.
So I'm going to ask both of you to go through the sections in the document, the major bullet points of the things that the document addresses, but did you address side effects in that age group? And
yes,
so,
we definitely did. That is, obviously very important in that age group, because if you have shorter time to achieve benefit, you definitely want to make sure that you use agents that are safe. So that is addressed in the document.
okay, so with that said, since this document is soon to be published, I'm going to ask you, well, I guess we'll start with you, Vera. What are the major bullet points that were addressed in the document?
Well, I think we can just go through the way that we structured the document. And so we basically asked 8 questions and then reviewed the evidence, relating to that topic area, and then came up with, appropriate recommendations that are extensively referenced. And so I can start with the first question that actually is asked quite a bit when I speak to primary care physicians or to patients, whether LDL cholesterol is still relevant in this age group. Because if you look at the relative risk that is associated with a cholesterol elevation, it is much more pronounced in younger individuals, but it's important to remember that the absolute risk of having an event for any given degree of LDL elevation is much greater in the older subset. And so it turns out that in this age group, over 75 years, LDL cholesterol remains a very powerful risk factor. And I think establishing that based on all the epidemiology that we know is a major first step.
That's very helpful. Joe, what would be the next bullet point that was discussed beside the correlation of LDL cholesterol and risk in the elderly age group?
Yes, another, I guess, challenge is how to accurately assess risk in this population, since a lot of our risk calculators don't go the full age span. They, pool cord equation goes up to age 79, and there's other tools that we looked at to give us more information. So we concluded that valid mortality indices that really do include the comorbid conditions and appreciate functional status are recommended. And there are some valid tools out there that should be used. There's more than we might think that are specific for the elderly population. So our analysis and evaluation of the literature led us down to that path, and hence we do have some ones that we recommend as valuable.
You made an important point there that I think all of our clinicians will appreciate, which is functional status, right? We're probably not going to be aggressively treating lipids in somebody who's in a nursing home with dementia as opposed to the rather healthy person for their age. So all of that needs to be considered. It's not just an age cutoff.
Absolutely, and some of these other there's more than one risk tool that we can consider. The pool cord equation is just one that does have limitations of going up to 79, but there's others that go up to, like the Q risk goes up to age 84, and the score 2 OP, it's European based, which is a limitation and gives us shorter term risk of as low as 5 years, but does go out to age 89. It's important, and these tools don't have the best ability of assessing always functional status, but we do address functional status in some of our latter conversations, especially when it comes to deprescribing.
So
Yeah,
Vera,
one of the advantages of that score to up that Joe just mentioned is that it adjusts for competing mortality, so you get a little bit better handle on the whole comorbid picture in an individual.
oh, that's very interesting. I look forward to reading about that. Vera, what about calcium scores in this age group? I assume you looked at that. We're using it more and more as a better risk assessment tool in younger individuals than all the equations that we have. So how did it turn out in the older individuals? And then I'll ask you for the next important bullet point in the document.
Yeah, we have data in individuals that are 76 to 80 years old that calcium scoring can be very helpful, primarily as a de-risking, instrument. So, if you have somebody in that age group who has an elevated LDL cholesterol, and that individual, has a calcium score of 0, they have something, genetic predisposition, susceptibility, lack of other risk factors that makes them probably less of a candidate to be treated. And then on the other hand, if you have individuals who have a calcium score above the 75th percentile for their age, sex, and race group, then in those individuals, if you're on the fence, you're going to be more likely to recommend treating than in somebody who has a much lower score. So, I think it can help us both with de-risking and further risk stratification.
Yeah, I can say clinically, a lot of people ask, do you ever get a 0 score in someone who's over 75? And you clearly do. We have all seen it as we start doing more and more calcium scores. Very reassuring for that patient. So I guess the third bullet point, and the one that's probably the prize winner, is does statin therapy reduce ASCVD events in this group, which would be the basis for treatment, obviously. So Vera, I'll ask you that question.
Yeah, that is obviously a key question, and we do have limited, data, but we do have some, studies that specifically, address this age group. Prosper being an example of it, and we have the meta-analysis from the clinical trials, trialist treatment collaboration, where they have, data both with, moderate intensity statin therapy and with, higher intensity statin therapy that all suggest that there is a benefit, provided that, you choose the individuals that you treat appropriately. And so our conclusion was that initiation of statin therapy in this particular age group may be reasonable in individuals without any life-limiting illness.
Fascinating. So, Joe, we talked a little bit earlier about potential side effects, and I know that was one of the issues that you were alluding to was discussed in the document. What can you tell us about side effect risk in this age group and benefit versus risk?
Yeah, I think the hardest part of answering that is fleshing out the exact benefit. But the good thing is when you look at the data, what we have available actually should give us more comfort about safety. And even the small risk of new onset diabetes seems to, if anything, you can build an argument that it may not be as significant in an older population, probably because if they were to develop new onset diabetes, it probably would have happened before they turned the age over 75. So looking at safety, as long as there's not a life-limiting illness, which really is, and that's somewhat vague, but it does imply that if you have longevity associated with your current status, you don't have a terminal diagnosis of cancer or end-stage COPD, if there's a longevity that's in your predicted future, that side effects are less a concern than we think. There are drug interactions that are not fully fleshed out in this document that must be considered because patients are often on multiple medicines and there's polypharmacy to consider. But in this whole decision pathway, part of your patient evaluation, one thing that really is probably the strongest recommendation, and it's obvious and it makes sense, and it really is tying to what Dr. Bittner said and what I was talking about a bit, is that because there are pros and cons, and sometimes I won't call it cloudy data, but not the traditional class 1 level of evidence A data to guide us, it really is important to use shared decision making. That's a very strong recommendation in educating your patient and having them be part of the decision of whether to treat or not, and then if the decision is to treat, how to treat.
And I suppose tolerance for any kind of side effects that were significant would be low in that group, right? You don't want to change their quality of life, which is what you're going for in the first place.
Absolutely. We don't want to decrease quality of life at all.
All right, well, we've gotten through half of the 8 points 8 questions that you guys asked, so I guess, or about 5 out of 8. So what strategy should we utilize in terms of dosing when you initiate the statin? What are you monitoring? Is there any, you alluded to the fact that there's good safety, so I assume you don't have to monitor LFTs routinely, et cetera. So Vera, I'm going to ask you about that. What are the strategies for the dose you pick to start, and then what are the safety monitoring recommendations?
Yeah, I mean, so there are a whole host of considerations here. I mean, number one is that since you have an older population that may have more comorbidities, I think it's incredibly important that we, think about those before we even start. So, I mean, one of them, for example, is, making sure that there's not a secondary elevation of, LDL cholesterol, given that, hypothyroidism, for example, is, highly prevalent. So you want to make sure that you have a good grasp of, your patient's, comorbidities, and don't layer, unnecessary statin therapy on top of it. But other than that, I mean, we basically adapted the recommendation from the standard lipid lowering guidelines, and that is that you want to, make sure that you monitor the individual once they get put on, therapy, so that you know that you achieve your, treatment goals, and you want to be sensitive to any sort of, adverse effects that come up. And so at baseline, we want to check liver enzymes, but we don't monitor them continuously unless the patient has issues. And we want to have at least a kind of what I would call a muscle inventory, so that you kind of know what sort of aches and pains individuals have, so that if they develop symptoms of a muscular nature later on, that A, what the baseline is, B, that you look for causes other than the statins, and if it turns out to be the statin after all, that you make appropriate dosage adjustments.
So that really rings true to me. I've gotten a lot of hugs from my elderly patients over the years as I hit 40 years, and into practice. But the biggest hugs are the ones where a patient came in and said they just felt terrible. They were fatigued. They were weak. They couldn't go up the stairs anymore. Maybe they were just getting old. And I looked and saw they were on a statin and told them, why don't you stop that? Let's see how you feel in a couple of weeks. And some of them come back in and just give me the biggest hug. They feel 10 years younger. So I know you addressed deprescribing and when it's appropriate to deprescribe. And I assume that may not only be in people who have myopathy. So Joe, what were the thoughts on deprescribing statins in this age group?
The thoughts about deprescribing really were more driven not from when patients have intolerance to statins, because we still have traditional strategies such as going to lower dose, trying a different statin, or maybe even considering a non-statin as an add-on or as a replacement, although that's a whole different pathway. But really the deprescribing traditionally would be considered when patients are really pulling back on therapy. And it really is when some other competing forces in there, and treating hypercholesterolemia in general is just not of concern. So you do think typically of patient preferences using shared decision making. Sometimes patients are just not interested in cardiovascular risk reduction therapy. I know that my mother-in-law is getting to that point where she's less and less interested about preventing something in the future because she's 90 years old. But some of that consideration really should be driven on reasons to not treat at all versus having problems with statin therapy. Obviously, if patients are having issues with tolerability, it does make you question, is the value there? Is the long-term benefit there? So it does force that decision. But if there still is good reason to treat, we can come up with an alternate plan. But you do get to a point with shared decision-making that you may decide to deprescribe. We're not encouraging any kind of explicit criteria, not age-based, not based on the number of things that might be present. It really is a one-on-one decision.
I can empathize with that. My mother is 99. She's a retired general practitioner. She's still got her wits about her. She doesn't even want blood draws because she said, what are you going to do with the results? I don't want anything done. So I totally get that. So that's just good judgment and really important to do what patients want at that age group. So the last bullet point, when should non-statin therapies be considered? In this age group, I just want to remind the audience, we're talking about primary prevention, so there's really not much discussion about secondary prevention. The patients at very high risk and we're going to treat them. But this document specifically addresses the patient over 75 who has not yet had a cardiovascular event. So Vera, I'm going to let you take that last bullet point.
Yeah, so just to be clear, so we're not really talking about combination therapy here, but alternate ways of, potentially lowering cholesterol in people who either don't want to take statins or, they have, intolerances. And so we do have some data from the, bempedoic acid, trials that is a, reasonable alternative. And we also have, data from Utopia that used ezetimibe in this, age range. And so we thought that both of these were reasonable, to consider, again, with, a big emphasis on shared decision making and discussing all the pros and cons.
I think in this, it's nice to be able to use a lower dose of statin and add ezetimibe in these patients to reduce the risk of potential side effects. I assume maybe you addressed that, but it's nice to do that in many patients. And at least retrospective analysis suggests if you achieve the same LDL, you get similar outcomes. Not perfect science, but that was encouraging to see that large retrospective case-controlled analysis.
And there is, with these recommendations, do take this as a clinical consensus document, an expert clinical consensus, where when we do make recommendations, they are evidence-based. And so when you don't have the evidence there, some of the things may not jump out in one of our recommendations, but might be implicit based on the explanation. So when you see as Vera eloquently stated, with ezetimibe, there are data looking at it as monotherapy in primary prevention. Not perfect data for an American population because it was done out of Japan using open label study design, but it does represent data that we need to consider collectively when appropriate. And with bempedoic acid, it is proven in statin intolerant patients, and they did have a pocket of patients that are in the above 75 group. Not exclusively, but it's there. So we have to, whenever you read one of these clinical consensus documents, when they have an evidence-based ranking, you have to remind yourself that it really is based on what's clear or what we have evidence for, and that some of the other expert decisions that you might make or expert opinions may not be clearly outlined as a recommendation.
Well, I'm personally thrilled that you guys put together an expert clinical consensus. I think that guidelines are based on what we absolutely know, but this kind of a document gives us some guidance when we don't have two prospective randomized trials for every question. And I think that our audience probably appreciates getting some clinical recommendations from experts, and this document looks like a perfect example of something they could look to that gives them as much evidence as available, but also good clinical judgment.
And we're really happy that it's going to come out before the two outcome trials will be made available, because there are two ongoing outcome trials looking at actually high-intensity atorvastatin, 40 milligrams a day in primary prevention older patients. So until we have that available, we need some guidance and be able to interpret what is available as far as our evidence base.
So I assume that when you authored this article, you ended up with some sort of an algorithm. Most of these types of papers do have a flow document as to what to do. So maybe, Vera, I'll start with you to kind of walk us through the evaluation and treatment for these patients and what the flow should look like, if you could do that I'm sure you can do it in an efficient way.
Well, I mean, it's basically, what we kind of discussed. It's, a patient evaluation first, and then let me just get down to the algorithm on my, thing here. Yeah, so I mean, it's basically, patient evaluation first, and then you have, this shared decision making, whether, statin therapy is appropriate in this individual or not. And then if you, decide that this individual merits treatment, but for some reason the, statins are not appropriate for this individual, then, consider, alternate therapies. And there's also, a separate limb that kind of discusses, deprescribing in, appropriate subsegments. I mean, it's just a very brief summary of the various points that, we've discussed.
So I guarantee you that people are thinking, what should my threshold be for LDL in this patient population? Do you make any recommendations on that? And, just starting a statin, what if they have FH, and we see primary prevention patients in this age group with FH, surprisingly. So, Joe, what do you think? What's the right LDL to be below?
The answer to that would be a personal opinion on my part, because we did not identify exact LDL goals because we didn't have the data to be confident in an exact number. I think if you commit to treatment, if you make that decision to invest in using a medication, my personal opinion would be I would want double digits. I would want to steer away from the triple digits. So I'm inclined, if answering that based on personal opinion, if you're going to probably treat to an LDL of at least 100.
Yeah, that would be my opinion also, based on no data, but that's what I would do in a younger individual, and I would be thinking 100 would be a reasonable number for primary prevention. Vera, any thoughts on that?
Oh, I mean, again, I think it's, it's the kind of type stuff that we don't have really, good data on. And so it's a clinical judgment call. If I put somebody on a dose and by chance it is an individual who is very responsive, they get an LDL that's, substantially, below what you guys just discussed, and they're tolerating the medication well, then I'm not going to go and backpedal. But as, kind of, initial, cutoff values, I mean, I agree with, what Joe said.
So let me ask you both, what if they have a calcium score of 300? So it's a primary prevention patient. Maybe you've done a stress test on them and it's negative, and they have a calcium score of 200 to 300, so they're in a fair percentile for their age. Would you go for 70?
I personally would. I was thinking the populations that would make me want to go lower would be the presence of diabetes and or subclinical atherosclerosis. And I think a CAC score is an example of that. My personal preference would be that's when I want to be tighter and go down to less than 70. Though you have to weigh the risks and benefits, and I love the point that if Vera emphasized that you look at tolerability on your current regimen, and if getting to less than 70 causes undue side effects, but less than 100 does not, then you make that patient-centered decision to just go less than 100, I think.
Yeah, that makes sense. Or if it costs them so much out of pocket that they can't go to the grocery store, those types of things. But a healthy 75-year-old who has an elevated calcium score is counting on you to reduce their risk of an event, right? And I think lower remains better.
And some people may argue for less than 55 in that group, too.
Right, right. So that's up for grabs. I think clinical judgment across the board is sort of what you guys have emphasized and what you're telling us today. Vera, any additional thoughts on that?
Well, no, basically, I think what has come out in our discussion is the tremendous heterogeneity that you have in that age group. From the, master athlete who still, runs more than the average 40-year-old, to somebody who is, very debilitated, frail, with, many, many comorbidities. And so, clinician judgment and working with the patient, being a team with the patient and any caregiver who is involved, is absolutely critical in this population. And so the shared decision-making is emphasized throughout the document.
Well, Dr. Vera Bittner, Dr. Joseph Saseen, thank you both for this tremendous insight. And I would encourage the audience, I suspect by the time the podcast is out there for you to be listening to, the article will be published. The National Lipid Association, along with the American Geriatric Society's expert clinical consensus on managing hypercholesterolemia in adults over 75 without a history of ASCVD. So I think we've covered all of the issues that are going to be discussed in the paper, and you'll be able to read in more depth what the background data was and how these decisions were made. And if you've wondered, is there any benefit to treating patients in this age group? And many times in my experience, those patients are most worried about cardiovascular events because they're in an age group where they've had a lot of their friends and relatives pass away. So they really often want aggressive therapy. So I would encourage everybody listening to take a look at this paper. It'll help you in your clinical practice. And I'd like to thank Joe and Vera for all their work as well as all the other authors, and look forward to feedback after the article is published.
Thank you, Alan. I appreciate it.
And
Thank you so much.
And thanks to the audience today for listening to this version of Lipid Insights.